This is Dr. John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital in New York, here to provide you with some updates in mantle cell lymphoma and T-cell lymphoma, particularly new data presented at the 2016 meeting of the American Society of Hematology in San Diego, California. I want to focus on two studies, one each in mantle cell lymphoma and in T-cell lymphoma, that I think are of particular interest to patients. Mantle cell lymphoma accounts for about 5 to 10% of patients with lymphoma. It is a lymphoma that is treated in a variety of different ways. It is more common in older men. However, there are also some younger patients that have mantle cell lymphoma as well. When patients with mantle cell lymphoma are diagnosed, different treatment approaches are often considered. Particularly in older patients, chemotherapy plus antibody therapy, namely a drug called rituximab, are commonly used as the initial treatment. For younger and fitter patients, in many cases, chemotherapy and rituximab therapy are often, though not always, followed by an autologous stem cell transplant, basically a fancy way of giving high-dose chemotherapy. That is commonly, though not universally, a treatment given to patients with mantle cell lymphoma if they are younger and fitter, meaning they don't have many other medical problems. And the data supporting that approach and why some patients and physicians consider it is that there are suggestions and good data that keeps people in remission longer. However, the data that it makes people live longer is actually less clear. And so mantle cell lymphoma often is a complicated discussion as part of its management with a doctor and a physician as to, do we use a more or less intensive approach? So the study presented at the hematology meetings applicable for this group of patients really focuses on the group of patients who have opted to go with the more aggressive treatment, namely those patients who get chemotherapy, rituximab, go into remission, and then get high-dose chemotherapy with autologous stem cell rescue. This study took those patients who went through that procedure and were in remission and randomly assigned them to receive a maintenance treatment of rituximab every 2 months, one infusion of rituximab, an anti-CD20 antibody, every 3 years, again for every 2 months, versus observation. So it asks the question, giving a maintenance treatment for 3 years for this group of patients, did that improve outcomes and to what degree? The net of this study is that this group of patients who received rituximab maintenance actually lived longer. There was a benefit in how many people not only were in remission, but were alive. And so these are overall survival data, commonly referred to, meaning that when you have studies that show that people actually are cured at a higher rate, or in this case live longer, that is pretty compelling evidence, assuming that the treatment is manageable in light of the fact that it can improve patients' survival, how many people are alive at given subsequent time points. And so I think these data are important in suggesting that patients with mantle cell lymphoma who are younger and fitter, in those who decide to get an autologous stem cell transplant, not necessarily everyone, but those who decide to get an autologous stem cell transplant benefit in a very meaningful way by getting maintenance rituximab treatment. And so for those patients who do get that more intensive treatment approach, maintenance rituximab should really very strongly be considered. The other study that I think is very important for another group of patients to know about relates to a type of T-cell lymphoma called cutaneous T-cell lymphoma. So T-cell lymphomas account for about 10% of non-Hodgkin's lymphomas, and about half of that group are patients with disease in various lymph nodes predominantly. Another half of that group largely is comprised of patients who have cutaneous or skin-based T-cell lymphoma. So for this group of patients, for much of the time of the disease, the problem is tumors or rashes or inflammations or nodules that affect the skin. And while these might not be life-threatening, They can be disabling in some cases, they can predispose to infections in some cases, and they can importantly be very uncomfortable and cosmetically a problem. So CTCL, or cutaneous T-cell lymphoma, can be a challenge for patients, particularly when their disease has become resistant to other treatments. So a study of great importance, I believe, that was presented at the American Society of Hematology meeting refers to a group of patients that were randomly assigned, where half of the patients received what's termed physician's choice, meaning that they received one of two standard therapies that are commonly given in practice, either methotrexate or bexarotene, versus a more novel drug or a newer drug, a drug called brentuximab vedotin, and that's a mouthful, but brentuximab vedotin is an antibody, an immune protein that is engineered to bind to a target called CD30 on lymphoma cells, including cutaneous T-cell lymphoma cells, and that antibody has hooked to it a chemotherapy drug. So the idea is that brentuximab vedotin is a targeted chemotherapy where the drug is directed at the CD30 molecule that's on the tumor cells. And so the question in this study was, which is a better treatment, the standard therapy or the brentuximab vedotin treatment? And the net of this clinical trial showed a clear benefit to the use of the brentuximab vedotin, the newer drug. The response rate, meaning improvement rate of the tumor to a significant degree, was markedly better with the brentuximab vedotin. About 67% of patients versus about 20% of patients had significant improvement. And the progression-free survival, meaning how long the disease stayed quiet, stayed in remission after treatment, was at least a year longer in the patients that got the brentuximab vedotin. So this take-home point from this study for patients and physicians is that for patients with cutaneous T-cell lymphoma, particularly those that have on their tumor cells the CD30 protein, which is a target of this therapy, should consider at some point in their treatment course treatment with brentuximab vedotin, an antibody drug conjugate or a targeted chemotherapy linked to an antibody treatment that delivers the treatment more specifically to the tumor. So to summarize, we have new data in mantle cell lymphoma and T-cell lymphoma presented at the American Society of Hematology 2016 meeting that really, I think, can potentially change practice for some patients in some situations with these diseases. Thank you very much.